All right, let's make a start. So hello and welcome everybody. The topic today is opioids in pain management. So my name is Carlos Bello and I'm one of the pain management clinicians of Eastern Health, and I'll be facilitating this webinar. Also helping is Eddie Purnell, and then also we should have Meredith Davies coming on as well to help. So this webinar is part of a series of webinars called the Pain Management Clinicians. These are designed to support medical and allied health practitioners to develop their knowledge and skills in the management of clients with complex pain presentations. So we try to record these webinars and post them for future reference. Some of the topics we have lined up include chronic pelvic pain, and that's going to be done by Dr. Glare Afay, who's one of our pain specialists. We also have health psychologist perspective on differential diagnosis of chronic pain, an introduction to addictions medicines, and also the role of psychiatry in the management of chronic pain. So a little bit of housekeeping for our webinar today. So please ensure you're on mute throughout the whole presentation. So we'll have about 25 to 30 minutes of the presentation, and then we'll have some time for questions. So we ask that you interact during the presentation through the chat option. Questions will be monitored and collated by myself, Meredith, and Eddie. And at the end of the presentation, we'll direct them to Jeremy. So also at the end, we'll provide details of the pain management clinic if you have any feedback or questions for us about the presentation. So I'd like to introduce our presenter. So our presenter is Jeremy Smerling, and he is the surgical team leader of at Box Hill Hospital and the acting senior theatre and perioperative medicines pharmacist for Eastern Health. So he's based at Box Hill Hospital, and he oversees the development of policies and procedures, guidelines and resources, the provision of educational programs and training for healthcare professionals and students, and the provision of quality improvement activities and research related to surgery and perioperative medicines. So Jeremy takes part in the acute pain service, including pain rounds across Eastern Health. He is involved in the multidisciplinary team meetings of the pain service and also the ambulatory pain management service case conferences. And he provides us with advice regarding complex pain presentations from a pharmacist perspective. So Jeremy has a Bachelor of Pharmacy from Monash University. He has a graduate certificate in pharmacy practice and has completed the Monash University Clinical Educators Training Program. So he's presented his research in the national level, including conferences such as the Society for Hospital Pharmacists National Conferences. So it's really great to have you along, Jeremy, especially I know that there might be a chance that you might be whisked off because of all of the things that are happening with the changes of the acute hospitals. So thank you for making the time to speak with us, and I'll hand over to you.
Thanks, Carlos. So good afternoon. As Carlos mentioned, my name's Jeremy. I'm the surgical team leader at Box Hill and also the acting senior theatre and perioperative medicine for Eastern Health. So I'm just going to stop for a sec. I can hear myself in my ears. Take that out. That might be a bit better. I can hear myself double. That's right. So today I want to talk to you about opioids. So are they the panacea for all our patients' pain problems? Or are they actually creating more problems for our pain patients than the reason that they needed them in the first place? So in terms of what I want to discuss in this webinar, I'm going to start with some background, then move into what's new with opioids. So I'll talk a bit about some of the statistics, what we might be seeing in the media. I'll discuss the ANZCA statement. So that's a statement by the Australian and New Zealand College of Anaesthetists regarding slow-release opioids and acute pain. I'll go through some of the new legislative changes, including safe script, permits, and a PBS. I'll then compare different opioids and discuss some atypical opioids like tapentadol and buprenorphine that you might be seeing more. I'll go through the importance of oral morphine equivalent dose, or OMED, in practice. I'll discuss some referral criteria for Eastern Health pain services. I'll try and differentiate between addiction, dependence, and tolerance, which can be confusing, and it's really important for our documentation and treatment plans. And lastly, I'll just go into some weaning of opioids or tapering, and lastly discuss opioid side effects with a focus on lesser known ones, so not sedation, constipation, nausea, etc. So it goes without saying, but pain is complex. It can be characterized as acute, recurrent, or chronic, which is probably what you encounter a bit more. And just to make it more complex, it can be acute on chronic, so an acute injury leading to chronic pain, recurrent acute pain, so the multiple acute episodes followed by remission. And it can also be characterized as nociceptive, neuropathic, or mixed. So nociceptive being someone breaks their leg and there's an activation of normal pain receptors to stimuli. Whereas neuropathic, we're talking more damage to the nervous system. So let's say someone hurts their back, it damages a nerve, they might get that nerve pain. But I mean, even then it's sort of a mixed state because you have that initial cause, which is the activation of the pain receptors. And I guess a more common example of a mixed case is things like cancer-related pain. So tumors often cause both nociceptive and neuropathic pain. But most importantly, pain is a personal experience. So the diagram really shows how different stimuli can affect a patient's perception of their pain. So things like beliefs and concerns about pains, psychological symptoms like anxiety or depression, and we know about a third of our chronic pain patients tend to have a psych history, and also things like cultural issues. And at the moment, we know COVID is causing additional stress for our patients, and we're definitely seeing our chronic pain patients present with more pain issues at the moment. So this brings us to our topic, are opioids panacea or poison? And I guess the answer is somewhere in the middle, although more and more literature evidence keeps coming out that shows the pendulum is swinging more towards poison, particularly in the long term. And recently we've seen some evidence come out around hyperalgesia. So this is where a patient receiving opioids for the treatment of pain actually becomes more sensitive to painful stimuli. And they're saying this could actually be a result of opioids sensitizing both neuronal and immune cells through something called toll-like receptors. And without going too far into it, it might actually explain why some of our acute pain patients become chronic, and it's all as a result of opioid prescribing. So we can easily see how GPs in particular face difficult decisions when asked to prescribe opioids, particularly to patients they don't know. So I was listening to Triple J last week, and they had a section on chronic pain, and a girl rang up and spoke about how she'd had crippling pain from undiagnosed endometriosis for more than 10 years. And she spent the whole time fighting with GPs and specialists and hospitals just to get the pain relief she needed, just to function day to day. And I felt terrible because we don't want our parents to experience pain. And I know that as part of the acute pain service in particular, we often get frustrated with GPs and private pain specialists when they prescribe lots of opioids. But I do have a strong belief that people in the health system just want to help people. And despite what I said on the last slide, opioids are not bad drugs, and they do have a place in treatment. We just need to be aware that there are risks associated with their use. So we know 3 people in Australia die and 150 are hospitalised every day due to harm from pharmaceutical opioids. And as you see there, 87.5% of those deaths are in that younger population. And just as a comparison, tonight we'll lock down the state of Victoria due to COVID. And since January this year, we've had 0.9 people die per day, so less than a third compared to opioids, and 1.5 people hospitalised per day in Australia. And I know it shouldn't be a comparison, but this just highlights we need to do more in the opioid space. So from a hospital perspective, we are a frequent site of opioid initiation, and more than 10% of opioid-naive surgical patients, so patients who are not using opioids pre-op, are still using opioids 90 days post-op. And so I was going to throw this question out, but I might just answer it myself. What do we think has the greatest influence on opioid use in opioid-naive surgical patients post-discharge? And the answer is literature evidence has shown us that for opioid-naive surgical patients, the quantity of opioid supplied on discharge has a greater influence on their use after 90 days than either pain severity or surgical type. And we often hear in hospital that prescribers are giving opioids just in case, as a kind act, but I think this stat really makes you reconsider this type of prescribing. So let's dig into some opioid statistics and what's new. So the graph shows the rate of accidental opioid deaths by type. And you can see number one is not heroin, it's actually naturally derived opioids like morphine and codeine. And if you look just at the end of the graph, I'll just highlight it. In 2016, pharmaceutical opioids had more than double the deaths per 100,000 population than heroin. And this graph shows the top 30 drugs contributing to overdose deaths. We can see that 20% are prescription opioids, and we have 2 in the top 5 and 3 in the top 7. And just with this graph as well, it highlights how frustrating it is that tramadol is not on SafeScript. So we'll talk a bit more about SafeScript later, but we actually monitor 5 drugs with less overdose deaths, so this seems like a massive oversight. Apologies, by the way, if I keep repeating words, it's because I can still hear myself in my ear. So to summarize those statistics, we now have an opioid crisis, and some are actually calling this a pandemic, and this has a special meaning at the moment, obviously, with COVID. So in the media, some people may have seen there's ongoing lawsuits at the moment with Purdue Pharma. So they're owned by the Sackler family, who developed OxyContin in 1995 as a breakthrough for chronic pain. So they've been accused of starting and sustaining the opioid crisis through deceptive company sales practices. They were aggressively pressing doctors to prescribe the drug, wooing them with free trips. They were doing paid speaking engagements, and essentially just spreading fake information, including the fact that they were saying that there was a low addiction potential, but it was found in court they had no evidence to back that up. So this was actually settled late last year with the trust set up for victims totaling $10 to $12 billion. But to put this into perspective, the company had already registered $35 billion in revenue in OxyContin by 2017, and probably much more since then. So it's less than 30% of that. And in what I think is a truly despicable twist, there's been some leaked documents through the court case that show Purdue Pharma actually tried to invest in Suboxone, which is used to treat opioid addiction. And more recently, they also patented a new form of buprenorphine approved by the FDA for opioid addiction. So they'll continue to benefit from the people they addicted to the drug they created. We've also seen a number of coroner's reports highlighting the risk of death of fentanyl patches. And in fact, in the hospital setting under the acute pain service, we're trying to restrict any initiation of fentanyl patches except for PowerCare and oncology. And just the last point is the Australian Medical Association Chief Medical Officer has sent letters to GPs around reduction in opioid use as well. There have also been numerous large public education campaigns in the media from different organisations, including the Therapeutic Goods Administration, which is the regulatory authority for all therapeutic goods in Australia, advocating for reduced opioid use. And like I mentioned earlier with the girl on Triple J, we keep seeing chronic pain patients going on various media, talking about the increased difficulty in getting prescription opioids and really feeling like they're being treated like drug addicts. Now, from a pharmacy perspective, they've recently come out with a new sticker, which is on the screen, which we now put on all opioids dispensed from any pharmacy, so community or hospital. And again, I was going to throw out to everyone listening what they thought of the sticker, but I might just ask at the end. I'll give you my initial thoughts. So I actually think this probably increases stigma around these drugs. And I'm also a bit concerned it might create a sense of fear in patients who are prescribed opioids appropriately. So I don't love it, but it's a good first step, I guess. So the ANZCA statement, which as I mentioned is the Australian and New Zealand College of Anaesthetists, was a big moment in pain management. So they came out in March 2018 and essentially said they no longer recommend using long-acting opioids in the management of acute pain. So an audit was done 6 months pre and post this statement, and you can see there was a massive reduction in the prescribing of slow-release opioids. So for inpatient surgical patients, it sort of went from almost 1 in 2 to 1 in 10. On discharge, it sort of went from 1 in 4 to 1 in 10. So that's a big drop. And the last dot point is probably the most important. So despite that massive drop, there's actually no increase in median pain scores for patients who are not prescribed slow-release opioids. And that's even after they adjusted for adjuvant, so things like paracetamol, non-steroidal use, and also surgical specialty. Another really big thing in the pain space is SafeScript. So SafeScript is real-time monitoring of prescription opioid prescribing and dispensing. So what can we get from SafeScript? Well, we can see any high-risk medication dispensing. That's all of your opioids, amphetamines, it's got quetiapine, it's got some of the sleeping tablets like Stilnox. It also tells you it's got some risk categorization built in. So you can see immediately things like if someone has a really high OMED, which I'll discuss later, any risky combinations, so benzos and opioids, for example. And if they have multiple providers, that's multiple prescribers or multiple pharmacies. So if they're doctor shopping, for example, you can see. Again, a question I'll probably just answer myself. So anything else you can get from there? So you can also see the permit situation, and I'll discuss permits in a second. A really good one is quantity kept at home. So if a patient comes in and says, I need a script, I've got no Tarjan at home, you can actually go in and see, well, 2 days private, they got 28 tablets, so you can know that. Another thing that's really good is misuse. So as an example, my wife's a doctor. She had a patient and was told anecdotally by the patient's wife that he was taking too much of his dexamphetamine, but the patient denied it. But using SafeScript, she could actually see that he'd picked up 30 tablets 6 days before, and it was a 1 tablet a day, and he brought the bottle in, he only had 2 tablets left. So it's a really good tool to help monitor these sort of drugs. So there've also been some big changes to the pharmaceutical benefit scheme. Just for those who aren't aware, the pharmaceutical benefit scheme, or the PBS, is run by the federal government, and it essentially subsidises the cost of medicine. So the price the patient pays for a medication is often well below its actual cost. And for any PBS listed medications, the patient only really pays a co-payment. So most patients, that's around $40 each time they go in. If they're concession, it's around $6. And the PBS has schedules. So it's got a general schedule, they call it, which means that a medication that's under the general schedule can be prescribed for any patient that a doctor thinks is appropriate. If it's a restricted benefit, it can only be prescribed for a certain therapeutic use. So for example, if a doctor wants to give codeine for a patient that says it's going to cure cancer, they can prescribe it, but the patient just can't get it subsidized by the government. So it's just an important point that the PBS restrictions aren't prescriber restrictions, that it's restrictions on what the government will actually pay for. And the last schedule is the authority schedule. So the prescriber actually needs to call and get an approval from the Department of Health. And there's an additional sort of subsection of that, which is streamline authorities. They don't actually need to call, they just pick a specific condition and circumstances from the options. So you can see here all the slow release opioids have actually been up-scheduled to the next ones. They were previously restricted, now they're streamline authority. So there's an example of, I think that's for OxyContin. And we can see that now to prescribe OxyContin with an authority, so to get it subsidized by the government, it needs to meet that criteria. So it has to be the chronic pain. It needs to require daily, continuous, long-term therapy. And there's some other things. So if it's for cancer, for example, it's okay. They have to make sure they've utilized all the other non-opioid medications first. So I guess the real positive from this change is that now it's really clear that these slow-release opioids are non-PBS, so not able to be subsidized for acute pain. So patients coming from hospital or into subacute, where it's for an acute pain, it's actually not. It's no longer going to be subsidized by the PBS. And I guess the negative is it's still quite broad for chronic pain. So if a patient has chronic pain, they probably meet most of those criteria. I'm not sure if I mentioned at the start as well, this has only started the 1st of June this year, so very recent. So they've also looked at codeine or Panadine Forte, which I think would be really relevant to this group. So previously it was general schedule and now it's restricted. So the restriction is on the page again. So you can see now it's restricted to severe pain, needs to be acute severe pain, and again talking about having tried other things first. So we commonly, so the positive I guess of that is that now it's clear that it's short-term acute pain only. But I think we'll find we have a lot of patients, and I've seen particularly come into these meetings, multidisciplinary team meetings, things like chronic back pain, they're all on Panadine Forte. It's actually no longer going to be subsidised by the government. So we might see a lot of patients either coming off it or having to pay more now because of this. I also want to touch on permits. I was asked to just quickly discuss because there's been some changes recently. So again, if you're not sure what permits are, so previously A doctor would need a permit to prescribe any opioids to a drug-dependent patient, or a patient who's non-drug dependent, so our pain patients, for more than 8 weeks of continuous therapy. So the change that's now been made is it's to do with permit requirements for our non-drug dependent patients in more than 8 weeks. These are our pain patients. That's the Department of Health safe script exception. So what they've said is that if the medical practitioner or nurse practitioner checks safe script in relation to the patient every single time they prescribe, then there are certain permit and notification requirements they don't have to follow. And then so I went a bit further to find what those certain requirements were. So from the SafeScript website, they've essentially said that anyone who has an OMED of less than 100 no longer needs a permit as long as they're checking SafeScript every time. This is the prescriber. But then I went a little bit further, and there's also a COVID exception. So this goes till the end of September, and I think it might end up being extended, which essentially says that if we have a non-drug dependent patient, a doctor or a nurse practitioner can prescribe these opioids or Schedule A medications for more than 8 weeks, as long as the patient's non-drug dependent, and also they're taking reasonable steps to check the safe script profile. So we're seeing a lot of patients coming through that don't have permits, and doctors aren't checking safe script every time. Particularly, I think it seems to be patients who are on it for a long time. But it's really important to feed back to GPs that it does need to be every time, because for all you know, even if you've been with the patient for a couple of years, they might be seeing someone in the middle. They may have gone to someone else to get additional scripts. And this is just a summary of that. That non-drug dependent patients, permits are no longer required as long as the prescriber checks safe script. So this will keep going, and we might find even after COVID, as safe script becomes more widely used, it should already be widely used, but as it becomes more widely used, it'll replace permits altogether. So I'm just going to quickly touch on this. This is coming out, it's not actually been done yet, but we're going to have an Eastern Health-wide objectified pain management guideline. It'll have things like, as you can see on the screen, an algorithm for prescribing on discharge, so trying to clean that up and keep it consistent. And also, as an inpatient, it'll have, I guess, a focus as well in terms of prescribing on moving away from numerical pain scores and moving to more functional pain scores, which Carlos told me, I think your teams tend to do quite a bit anyway. So this slide shows a comparison of the common opioids you're going to see. So it's good as a reference for dosing, but in particular, I really want to focus on its utility in practice. So in terms of time to onset, if we know a patient's having a physio session, we may want them to take their PRN to pentanol tramadol earlier than we'd want them to take their oxycodone, for example, because we know it takes that little bit longer to work. So maybe rather than saying 15, 20 minutes before their session, you're saying 30, 40 minutes before their session. And in terms of duration of action, I just want to touch on this. This may be more for prescribers, but it's also really relevant to anyone who's checking charts. So there's a big difference between charting a medication QID versus 6 hourly, or TDS 8 hourly, BD 12 hourly. So BD, TDS, QID is a frequency to give a medication during waking hours. 12, 8, or 6 hourly is a frequency you can give a medication over 24 hours. So we often see paracetamol charted 6 hourly instead of QID, and this means nursing staff end up waking patients up overnight for Panadol. And I guess the relevance to duration of action is that we really should be seeing our PRN opioids charted as an hourly dose, so for example, 4 hourly with a max dose. And the timing is actually not about frequency, so when we say 4 hourly, we don't mean 6 doses a day. It just means you need to wait 4 hours between doses, and this is where the duration of action comes into play. And we often get confusion, particularly on discharge. So someone might get a script for oxycodone 6 hourly PRN. When we ask the prescriber, they chose the frequency just to match a max dose they want of 20 milligrams. But the patient can actually take it safely every 4 hours, and that'll help with their function. You know, that we don't want them not taking it if it's been less than 6 hours when they need to go shopping or have a shower, etc. And lastly, from this table, I just wanted to touch on it being important to know about the idea of a prodrug. So we can see on the table codeine and tramadol are prodrugs. So it means they're inactive until they're metabolized by the body to produce an active drug. This essentially means how much active drug the patient gets is dependent on their genetics and comorbidities. So if someone has a liver disease, for example, liver issues, it can affect their metabolic enzyme production. So for codeine, as a good example, one patient might get little or no effect, whereas another might get a full hit of morphine on the exact same dose. And this is really why we're trying to move away from codeine. Again, this table is more for reference. It just shows the best options for patients with renal or hepatic impairment, for children, for pregnant or breastfeeding patients. In particular, I just want to point out, for pregnancy breastfeeding patients, we all have access to the Women's Guidelines through Clinicians Health Channel, and it's just a really great reference. It often has advice, particularly around breastfeeding patients, like monitoring points for the baby and taking doses just after breastfeeding to minimize drug levels. So this statement was more for inpatients in hospital, where everyone seems to be on tapentadol. It is rarer in the community, and it's because the immediate release is actually not covered under the PBS. So a patient who goes to Chemist Warehouse will pay $1 per tablet from Chemist Warehouse of tapentadol, whereas they only pay about 35 cents for their endone. However, there are some really good reasons why we might suggest it to our community of patients, even at the higher cost. So essentially, tapentadol, I don't love this wording, but it's sort of an improved version of tramadol. So it still has the mu agonism. So mu receptors are the main receptors targeted by opioids to reduce pain transmission. But the lower mu agonism explains why there's less evidence of abuse or diversion, and also makes it a bit safer in terms of things like respiratory depression in overdose. It also has a lower serotonergic effect than tramadol. So tramadol works on serotonin receptors as well, and that can cause things like serotonin syndrome. It can lower seizure threshold, etc. So the lower serotonergic effect is definitely helpful. Really importantly, it's got data for chronic pain. So it's been shown to improve quality of life. And it's got data for both nociceptive pain, but also neuropathic pain as well. So going back to the idea of a prodrug, tapentadol is not a prodrug, whereas tramadol is. So it's no longer dependent on enzyme activity. So you don't need to worry about the genetics. It's fairly safe in overdose. Like I mentioned, that's to do with that lower mu agonism. It can be used in renal failure. And in fact, the renal team at Box Hill Hospital have it as their first option. It causes a bit of less constipation than Targen. And I'll discuss immunosuppression with chronic long-term use of opioids, but we haven't seen the same immunosuppression we've seen with oxycodone as we've seen with tapentadol. So I've just stolen this table, but it's a comparison tapentadol versus oxycodone or endone. So you can see it's a 5-to-1 ratio. So your 50 milligram tapentadol is 10 milligrams of oxycodone equivalent. Adverse effects wise, it's better for GI side effects, skin reactions, testosterone suppression, but it's about the same for some of those CNS effects, so things like sedation. It can be used for neuropathic as well as somatic or nociceptive pain. And the physical dependence is a bit lower. And again, this is just for reference. It's got some doses, and these slides will be available for people to have a look at. But it's straight from things like the AMH. So some tips, because I do think we'll start to see more IR tapentadol or tapentadol in general. So the slow release is PBS funded, so they can get that subsidy from the government, but IR tapentadol is not. So just if you have patients you want to start on it who are already on it, it's important they're aware of the financial impact, and we're also aware of the financial impact of our patients. So it's unusual in the sense that you normally can't cut or crush slow release formulations. With tapentadol, you actually can't cut the immediate release either, because it causes a rapid release of the drugs. That's important for patients who can't swallow the tablets. It can be more sedating than a low-dose Targen. Physical dependency can still occur. So we said it's got less risk of dependence, but it can still occur, and you need to be reminding patients about withdrawal symptoms if they're coming off it. And also, because it does have that lower, I've said opioid activity, I'm talking about mu receptor activity. Switching from a high-dose conventional opioid like oxycodone to tapentadol straight away can actually precipitate withdrawal. So I'll also quickly touch on I've spelled it wrong there, but buprenorphine. That's another one we're seeing more and more. So we're not entirely clear how it works. It works on multiple receptors in the brain. It has a ceiling effect on respiratory depression, so it's reasonably safe in overdose. It has less of the side effects we were talking about, so things like constipation, cognitive impairment. The risk of dependency is a bit lower as well, and withdrawal. Safe in renal failure, again, used in renal patients. It has a really long half-life, but it's also available in sublingual form. So that means it actually works really quickly, but lasts long. So two of the sublingual things you might see are the Suboxone sublingual films. So that's buprenorphine with naloxone. There's also Subutex, which is just buprenorphine. And this is marketed for opioid replacement therapy, so not for pain. So the drug cost is actually carried by the federal government and patients don't pay for it. But we have been seeing some chronic pain patients buying this privately, so you might see this around. The other one is Temgesic, which is again sublingual buprenorphine. This one's actually marketed for pain, but it's only available on a private prescription, so it's not subsidized by the government, and it is quite expensive. So it works pretty quickly, 10 to 15 minutes, and the usual dose, you normally give it 4 to 6 hourly. So moving on to OMED, so oral morphine equivalent dose. So I'll go through what that means in a second, but I think everyone listening should really download this app, available on Apple and Android. Essentially, it just allows you to calculate an equivalent dose of morphine for whatever your patient is taking, and also allows you to then convert to other opioids if they need to switch. So this is an example of what it looks like. So you can see that it has all the oral options, it's got sublingual options, transdermal, IV options. You can put in multiples, so they might be on oxycodone and tramadol, for example. It'll then give you the morphine equivalent, and it'll give you a bit of a color coding to tell you if it's something that you should be worried about, I guess. I'm not actually sure what the cutoff is, but it looks like it's about 100 to get to red. And then you click on the go button, and it'll actually convert it to all the other options for opioids. So you can see, if you compare the left and the right screenshots, that 20 milligrams of oxycodone is equivalent, for example, to 100 milligrams a day of tapentadol. It's a really good app, and I'd highly recommend everybody get it. So with OMED, I'll probably put those dot points in the wrong order, but essentially it reflects the different potency and analgesic properties of the opioids. So we know from literature evidence there's a significantly higher risk of death if OMED is greater than 100 milligrams. Now, in terms of how to use it, it's really important to talk about the idea of dose reduction. So 5 milligrams QID of oxycodone, which is really common as a PRN dose, is an OMED of 30 milligrams, and that equates roughly to a fentanyl patch, the lowest strength, at 12 microgram per hour. However, we always need to dose reduce if we want to switch between opioids. It's not one-to-one, and that's because of this idea of incomplete cross-tolerance. So if you're taking oxycodone for a while, you become tolerant to the oxycodone. When you then switch to a different opioid, you don't necessarily maintain that tolerance, and then you might end up getting a greater than anticipated potency and therefore a risk of toxicity. So very important, if you do see a switch, it is reduced by at least 50%, if not 75%. So I just want to quickly discuss pharmacy involvement at a subacute site. So Wantana, we have 2 pharmacists. PJC, we have 3. Anglis has more, but only 1 specifically responsible for subacute wards. So it means that the patient to pharmacist ratio often results in pharmacy only really properly assessing patients on admission and on discharge. And when pain issues do arise during the admission, pharmacy are often not involved, and we don't know about it until the patient's ready to go. But we can really, on the wards, be a great resource, both for drug information and also pharmacy services in the community. So things like Webster Pack, stage supply, medication reconciliation checks. So I wanted to use this slide. It's referral to acute pain services for inpatients, but it's also useful as, I guess, triggers, particularly for allied health staff, as to when they should potentially be speaking to pharmacy or the medical team, so that it sort of happens before that point of discharge. So some of the big ones there, high OMED, more than 60 milligrams is sort of the cutoff any significant pre-existing opioids, so if there are a lot of stuff before they come to hospital, if there are multiple SR opioids, so we often see things like Norspan patches, Vitargen, and really any pain that's difficult to control. So if they're on, escalating doses of opioids while they're in that subacute setting, they really should be referred on. And a really good example of how important the referral is. So we had an opioid naive GenMed patient. They're on low dose Targen, not really using any PRNs, but the GenMed team wanted to escalate to a fentanyl patch because the patient kept saying their pain was poorly controlled. And because we had Allied Health come to pharmacy and then we went to APS, they actually ended up just being managed with appropriate use of PRN and multimodal analgesia and avoided that drastic increase in OMED. So moving on to this really important distinction between addiction, dependence, and tolerance. So again, I was going to ask if anyone wanted to try and define the differences, but I might just go into it myself. And the reason, I guess, just to go back a step, the reason the distinction is really important is because the labels we put in the documentation we use can actually impact treatment choices. So just as a definition, I guess addiction is that compulsive use despite negative consequences. Tolerance is decreased effectiveness over time. And dependence is when abstinence causes withdrawal. And there is obviously crossover. A lot of people seem to find it difficult to move between psychological dependence and addiction and whether they're the same or not. But it's important that we're clear on what we're trying to treat. So if it's addiction med, that's actually, we call it a disease state. It's a diagnosis. And they need to be referred to addiction med. So addiction med are the specialists in that area, and they should move away from the pain service. If we're thinking it's tolerance, then that's when we really refer to APS in the acute setting, obviously. And then we want to look at switching therapy. So doing things like opioid rotation, moving to another one is often better than just continually increasing the dose. And if we're thinking that it's dependence, again, acute pain service are a really good resource. But then, and I'll talk about weaning, but at that point, we're really looking at a weaning plan. So moving on to weaning plans, when do we want to use weaning plans? Really when we're treating non-cancer chronic pain and either the treatment is inadequate or the duration is really long, so more than 90 days they're put there. If we're getting any significant adverse effects, if it's been used unnecessarily after the acute pain period or the acute pain treatment, or if there's any sort of risk of misuse or any risk of overdose. So how do we do it? I've put some really general advice there. It's really going to be dependent on the opioid and how long they've been on it. But short-term exposure, we're normally happy to reduce the daily dose by 10 to 25% each week. Longer-term exposure, so we're talking years, you then look at reducing the daily dose by 10 to 25% each month. But as part of those new pain guidelines, we're planning to have usable dose tapering plans or dose weaning plans for both short and long-term exposure and using different opioids. That'll be really useful. So chronic side effects. And again, I was going to ask a question because everyone, when we think about side effects, particularly from pharmacy, we tell every patient, look out for constipation, sedation, and nausea, but there are some other really significant side effects that we should be aware of and that can help, particularly when we're talking to patients about chronic use of opioids. So I sort of previously mentioned opioid-induced hyperalgesia, but there's a good definition there. So it's a paradoxical response where a patient receiving opioids for treatment of pain, and it's particularly long-term, may actually become more sensitive to certain painful stimuli. Then you also have opioid-induced allodynia that can happen, which is they get pain from ordinarily non-painful stimuli. We see neurotoxicity with long-term chronic use, suppression of the hypothalamic pituitary adrenal axis, which essentially causes things like reduced sex drive, impotence, fatigue, affects their mood. Immunosuppression, and that's a really important one. I know in an inpatient setting, it's often used for renal patients who do have pain issues, renal transplant patients. Osteoporotic fracture. So this becomes a circular thing where patients might come in for a fracture, they get put on opioids, they're on them long term, the chronic use then makes them more likely to get more fractures when they then need to increase their doses, etc. So it's important to be aware. Myoclonus, which is muscle jerks, depression, anxiety, and also, as mentioned, physical and psychological dependence. So I guess when we're having a conversation with patients who have long-term use of opioids, we can try and tailor what we're saying to the patient. So I've just put two examples here. So for example, if you have an anxious patient, you can talk about the fact that it can actually increase their anxiety, potentially cause depression. Things like hyperalgesia and allodynia might be useful to mention as reasons to help them agree to, say, a weaning plan. Or if you have younger patients, talking about things like reduced sex drive, or young male patients planning to have children, impotence might be something you can mention as a way to guide that conversation. So that's really all I wanted to discuss in this presentation. And I'm happy to take questions. I have noted that lots of people have put questions on the chat. So Carlos, I don't know if you want to open it up to people to verbally ask, or you want me to just go through the chat?
Maybe what we can do is, as we're unmuting people, we can ask you to go through the chat questions.
Yes, that's good.
We also have Gordon Maher here as well, who, maybe we can ask Gordon to also be available to answer questions.
Definitely, and so Gordon is also the key author on that pain guideline I was talking about.
So I guess there's if you want to go through some of the questions, I think one of the questions Eddie asked was how common is hyperalgesia caused from opioid use? Is it sort of like everybody develops this, or is it certain phenotypes or something like that?
So I don't know what the evidence is around that. I know that we have seen it in even acute patients sometimes, but it's something that's often more recognized in the sort of chronic pain patients. And it just ends up resulting in dose escalation. They become, they get the hyperalgesia, then they need more and more pain relief. And really we're hurting more than helping by giving them more and more opioids. And I don't know if Gordon knows more around the evidence around that, but I do know that it's more recognized in that chronic pain patient cohort.
Yeah, thanks, Jeremy. I think it's usually a real clinical conundrum because, you've got a patient who perhaps is saying that their pain is escalating despite their opiate, and differentiating, say, the opiate-induced hyperalgesia to, is it just tolerance? Is the patient just more tolerant to the opiate? Is really hard to differentiate. So if you're really confident about the diagnosis, you could just reduce the opiate and see if it leads to an improvement. But often you're going to have a lot of trouble convincing your patient that that's the best course. So that's where a rotation to a drug like buprenorphine or methadone can lead to some benefit. So that's normally what you do. It's one of the arguments behind rotating chronic pain patients to methadone.
So someone's asked why tramadol is not on SafeScript. It's a great question, and I don't have an answer. I think it's a massive oversight. I do know that we are seeing more and more tramadol in the community, and I do wonder if part of it is because GPs are aware that it's not going to show up on SafeScript. And I just hope it's something that they review and put on there, because as that slide showed with the top 30 drugs, there are multiple drugs below it, including benzos and other opioids, that are being recorded, and recording things like quetiapine, not recording tramadol.
Jeremy, did you see my question about serotonin syndrome?
Is that with tapentadol?
I think in general with serotonin syndrome, I'm actually not sure what that would look like, and how I could pick that up clinically.
So with serotonin syndrome is often misunderstood a little bit in the sense that we call it a drug interaction, but if someone's on, say, tramadol and an SSRI, they're not necessarily more likely. It's more just an additive effect. So like we say, multiple opioids is additive sedation. There's a more chance, the more serotonin that's there, that you're going to get serotonin syndrome. Is that sort of what and I guess with tapentadol, people often ask me if they're on tapentadol, is at a risk of serotonin syndrome? So unlike tramadol, which directly works on serotonin, tapentadol doesn't directly work on serotonin, but it does work on other brain chemicals, which might end up resulting in more serotonin. So it's not listed on most tables for serotonin syndrome, but we have anecdotally seen it happen.
What are the symptoms of serotonin syndrome?
It's a really good question.
And often it's hard do you want me to answer that, Jeremy?
Yeah, sure. I mean, I was just. Oh, yeah, you can answer it if you want.
It's a bit like a malignant hypothermia type situation. So hypothermia, hypotonia, hyperreflexia. So that would be sort of mainly what you're looking for. So you become sort of hypermetabolic.
And I know in practice, the few times I've seen serotonin syndrome, it's so bad I can hear myself talk. I have to take my headphones out. So often when we see it in practice, it is that sort of fever, muscle rigidity, and they're sort of looking for a reason. And when you look into the medications, it becomes clear, they've increased their dose of their SSRI, they're on tramadol, etc. That's the ones I've seen in practice, but it can be as serious as seizures and death. It's quite a serious condition.
Jeremy, I asked about the shift. Well, I've noticed a shift from pain doctors prescribing short acting opioids now, more so for chronic pain patients versus in the past prescribing slow release opioids. And I just wondered, what's the evidence behind this shift?
So I think Gordon answered that in the chat.
He just talked about episodic pain, yeah, but I'm talking chronic pain. So most of our chronic pain patients have a sort of a continual level of pain, and then they have, increases, but they have quite a sort of heightened level of, say, 5 or 6.
Yeah, and I think it goes back to that idea of hyperalgesia and whether if we keep giving them these slow release, are we actually making it worse for these chronic patients versus looking at their function and saying, all right, well, is there an effect on their function day to day? And can we just use it for episodic pain throughout the day for these chronic patients?
Yeah.
And then we're reducing their overall load and removing some of those long-term side effects we were talking about, like immunosuppression and.
Yeah, I think certainly in our discussions at our multidisciplinary pain meeting, we the idea is not so much to get rid of slow release opiates in patients that are taking it for persistent pain, but I suppose just to reduce the amount of slow release opiate and try to use perhaps immediate release opiates for more episodic related pain. If back pain flares up at certain times of the day or certain activities, you could perhaps use the immediate release for that, but still continue your slow release opiate, but try to then reduce the total dose.
And I think someone's written in the chat, according to Stephen Shug, no SS risk with tapentadol. It's not in any of the tables you'll find for serotonin syndrome, and it is pretty safe in that space. Just anecdotally, we've had a few situations where we think maybe tapentadol's involved. And again, it's not a direct action on serotonin receptors. It's more about the fact that you're affecting other receptors in the brain, the chemicals change a bit, and then maybe getting more serotonin in some patients. But it's not something I'd worry about. And it's a definite advantage over something like tramadol, which is very clear in its effect on serotonin.
Yeah. The tapentadol product information does say that serotonin syndrome is a possibility, but Stefan Schulgier, who does a lot of the public speaking on the product and was part of the development of the drug, says that there is no serotonin syndrome. So,
and so someone's asked about rotating and switching, and is there a risk for withdrawal? So there is a risk. Hopefully it would be done in a setting where they can be monitored pretty closely. It's a really good place in a subacute setting or an acute setting where we can watch them and monitor them to do that switch. Because like I said, you do have that incomplete cross tolerance. And you also have, for example, tapentadol having that lower mu affinity, a lower mu action. And then if you're switching from oxycodone to tapentadol, you might actually get some withdrawal symptoms. So I think it's really important they are medically reviewed when that's happening.
So can I ask a question about that? That question came from me. So if the clients, so in our pain service, often the doctors will rotate them, and they might be having physio with me a week after while they're rotating, and they might be experiencing some withdrawal symptoms. Is it sort of an urgent medical review? Should they go to their GP, or do you think it's they could see someone in a week? What would you suggest? Like, obviously, it's really uncomfortable for the client. It's a terrible situation to be in.
Yeah, look, it's a really good question. I think it just depends on how uncomfortable it is.
Yeah.
So if we're talking, they're really uncomfortable sweating, heart rate's up,
Yep.
You probably want them to go see someone straight away. If they're just, maybe they're having things like gastric things, diarrhea and stuff,
Yeah.
and they feel like they're managing, they should probably still see their GP just to get reviewed, but versus there being, I guess, a medical emergency. But again, I don't work in the community, so I'm not sure. I mean, at the moment with telehealth, they can probably get into GPs really quickly because they don't actually have to go themselves. So it'd be reasonable to ask them to just make that telehealth appointment, talk to the GP about what's happening, and be guided by what they say.
Jeremy, Ernie has asked a question about the CRP setting. Ernie's been unmuted.
Yeah, hi, Jeremy. My question is just regarding some acute ortho patients. So we might have total knee replacements. And I guess some of the directive now is trying to wean them off the opioids super early. And so we have the struggle sometimes where they can't really do their physio. And it becomes a bit of a challenge for us to try to convince the GP and the patient that actually they need to have some sort of analgesia. Otherwise, they just can't do the therapy. Thoughts?
So,
yeah.
So in the acute setting, like you said, we have a really strong push to either not use slow release opioids, or if you are, just have it time limited.
Yep.
I think what we find, particularly with ortho patients, is there's not necessarily good use of the IR options, as in the PRNs. So particularly around physio, thinking about that, time to onset, just making it really clear, and if you're talking to the GP in a letter or discharge summary, just being really clear on when they should be using it. So they're going to go out, they're going to have a physio session half an hour before. That's the use you're asking for. And I think if you're really clear about what you're using it for, then they'll probably be more comfortable with doing it. I know from hospital setting, when people go home, we do restrict the quantity even of immediate release. And we have that, really good conversation with the patient about when they should be using it. And again, another really important thing about inpatients going home is making use of adjuvants. Often, for example, orthopedic patients, we might get a script with just endone. And then we then have that conversation, go get Panadol, go get Nurofen, use a max dose before you worry about using this, or use this for activity-related pain if you're going to go to physio. So maybe, and we're trying to move to that with this pain management guideline, is maybe the script should have the Panadol and Nurofen. So it's really clear that there's a step-by-step process, and that might also make GPs more comfortable with the opioids you're prescribing.
Yeah. Okay, thanks.
Jeremy, about that. So with the adjuvants, so Nurofen, I've heard, has the, likelihood of bleeds, that sort of stuff. Thoughts about adjuvants, and I heard that sort of meloxicam is probably like the better, Mobic is sort of like a better adjuvant for.
So we use a lot of celecoxib as well in a hospital setting. So I think, and we're trying to address this in our pain guideline. There's a lot of prescriber worry around non-steroidals. They're quite safe in a short duration with a set end date, and they're really good at being opioid sparing. So using them means you don't have to go use your endone, your slow release Tarjan, whatever it is. So I think, there is that slight increased bleeding risk. People often worry about the patient's kidneys if they have some renal impairment. They also worry about gastric things if they've got reflux or ulcers. I think it's a really important medication. It should be I guess we start by saying they should be on these sort of medications in a short term, and then we say these are the people who shouldn't be on it, versus just a couple of people are on it. I'm not sure if that answers your question.
I guess it does in some ways.
Sorry.
No problems.
Yeah.
I guess, so Loris has asked a question. I don't know if Loris is unmuted, but I'll just ask it for her. So many chronic pain patients want to reduce their drug use. How is it best managed, GP or specialist? It's a big question.
Yeah, and it's hard for me to answer. Again, I don't work in the community, but I think it's really important when the transition of care is an area of risk and one we know is a really high risk time. I think that, and again, you might be talking about those longer term patients, but what we want is that the doctors, before they leave, to have a really clear plan on how to manage those, particularly slow release opioids, having that set weaning plan so that the GP can then just follow the plan, whether it's reducing 10 to 25% once a month or once a week or whatever it is. If patients are on it long term, I think really we just need more education for GPs around how to do this weaning, because a proper weaning plan tends to be quite safe for the patient. And I just think, and I don't know because I don't speak to GPs on a regular basis, but I think maybe they're just, in the short sessions they've got, it's often quite difficult to make that weaning plan.
If I could just say something, Jeremy.
Yeah.
Like, I think often with chronic pain, they talk about, that whole iceberg analogy. Chronic pain physicians really only deal with the tip of the iceberg. GPs deal with at least 80% of community pain, and they do a good job in reducing opiates. So I think it's still the primary, the GP is primarily responsible and would do the majority of weaning of opiates. But patients that are that are more complex, have very high OMEDs, a lot of psychosocial factors. They can be very, they can derive huge benefit from chronic pain specialists and multidisciplinary clinics. But as you'd be aware, it's the waiting times can be very long for public clinics, and private clinics are expensive. So I think it still comes down to the GPs to deal with a lot of it.
And I just wanted to answer one of the questions in the chat. So I think it's a really good question. It's around Panadol Osteo. Yeah. So we see a lot of it, particularly in patients with things like arthritis. Long-term, using it regularly is fine. But for acute patients who, post-surgery, often normal Panadol 2 QID is a lot better. You get a faster onset of action, and it tends to help control their pain a lot better. So often we get patients who are already on Panadol Osteo, and then when they go, the doctors just restart the Panadol Osteo and stop the regular Panadol. But I'll often tell them, for the next couple of days at least, use normal Panadol, because you'll find that quicker action actually helps. And in terms of why it's on script, I think it's actually a bit cheaper on script, particularly because you can get 2 boxes for one price. So I think they just know it's quite useful for these arthritis patients and are trying to subsidize it. But I don't know the background of that.
Thank you.
I think we have run out of time for any more questions. If you have any other questions, please direct them to myself or the pain management clinicians email address. So on behalf of the audience, I'd like to say a big thank you to an extremely informative presentation. And it really demonstrates and highlights the specialist skills that each discipline has that attends a multidisciplinary pain meeting or case conference. So thank you for your generosity, and also thank you for continuing to be involved in our service, Jeremy. It's been really fantastic having you, and Eddie's there, nodding her head. Yeah.
It's been great having you in our clinic. Yeah.
Yeah.
Thanks, everyone. I really appreciate it.
So I'd like to thank also the participants for joining us today. Hopefully we covered all of the questions. Again, feel free to email us on painmanagementclinic@easternhealth.org.au. And that brings us to an end. Thank you very much all for coming.